Hi everyone, this is Dr. Rakshit. In this video, we'll be talking about fracture management. When it comes to MRCS, there are a lot of questions that have been asked repeatedly regarding fracture management. Different types of fracture, whether it's open fracture, there's closed fracture. There are multiple types of management. Today, we'll try to discuss a few questions that have been repeatedly asked in the exam, and we'll try to discuss the concepts of the same. So starting with the first question here, a 80-year-old woman has hip fracture. Her calcium is normal. She has never been given a diagnosis of osteoporosis. Apart from treating her hip fractures, what additional intervention should be considered? So we'll discuss why is this a special case first, why a 80-year-old female, and why this treatment here in 80-year-old female differs compared to a 40-year-old female. So this is what we'll try to discuss here. So mainly fractures can be open fracture or a closed fracture. It can be closed fracture or open fracture, or it can be simple. In closed fractures, there are multiple types of fracture. Here, they are talking about a closed fracture around the hip joint. So, hip joint fractures, very commonly called as the fragility fractures. So, what are these fragility fractures? Is when the patient ages, especially females after the menopause, they usually have fragility fractures because of decreased estrogen. When the estrogen decreases, the bone tend to be osteoporotic. So, because of this osteoporosity of the bones and weakness of the bones, even a small trauma and mild trauma can impact a fracture. Okay, so in these fractures, the problem with these fractures is we can manage these fractures like any other fracture. You can do a surgery, you can do a conservative management. The problem is these fractures won't heal in the proper way as expected because of the decreased calcium concentration in the bones. Osteoporosis is a condition where the calcium concentration is normal in the blood. When you get the calcium concentration, it's normal in the blood. The problem is here when you see the bones, the architecture of the bones, it's very compact normally. It's very compact normally, and the spaces is very less. But you see, when you see osteoporotic bone, it's not that compact. So it's more of fragile and a lot of spaces, air spaces between the bones here. So that is why it becomes osteoporotic and fragile. So there's a fracture here. Okay, even if you fix this fracture might not heal because the calcium is there, but this calcium is not being exactly laid down on the bones. Okay, so it's fragile. So now what we have to do is we have to give some supplements here. So what should these supplements do? These supplements will increase the density of the bone. So that is our main concern here when it comes to osteoporotic fracture. So what are we going to give? We can give calcium supplements. Just giving calcium supplements is not going to serve any purpose. Okay, we have to supplement it with vitamin D. So what is the function of vitamin D is vitamin D helps in absorption of the calcium from the gut. Okay, when you're supplementing the patient with vitamin D, the absorption is carried out by the vitamin. When you're giving calcium here, vitamin D causes absorption of calcium from the gut. Okay, so why are you giving bisphosphonates here? We can give bisphosphonates. What does bisphosphonates do is it decreases the osteoclastic activity. We know there are two kinds of cells. One is osteoclast, one is osteoblast. So osteoblast basically is lying down the bone. Osteoclast is removing the bone. So what does bisphosphonate do? It basically inhibits osteoclastic action. So what does osteoblast do? Osteoblasts continue laying of the calcium on the matrix here. So because of this laying of the calcium over the matrix, the bone density will increase and the fragility will decrease. So this is the plus point of adding this. If we just operate this patient and just leave it like that, the bone density might not improve and the fracture might not heal and the fracture might not unite. And in the future also, this patient might have more amount of fractures. To prevent that, apart from treating the patients with osteoporosis just with a fracture reduction or a fixation, we have to make sure we have given them proper supplements as well. So there is one more option, that is option E here. So what does option E say? DEXA scan. So what is a DEXA scan? Dual energy X-ray absorptiometry. So DEXA scan is basically to understand whether the bone is fragile or not. To understand a T-score. So what is the T-score is? T-score is to understand whether there is osteoporosis or not. It's a comparative score to understand whether there is osteoporosis less than minus 2.5 is known as osteoporotic. Okay, so if to understand the T-score, we get a DEXA scan. So here we're easily understanding it's 8-year-old female, so we can easily get to know whether this patient has osteoporosis or not, even by looking at X-ray, by thinning out of cortices. By that way, also we can understand this patient has osteoporosis. The DEXA scan is only going to confirm the diagnosis of osteoporosis, which we would have got the diagnosis easily by an X-ray itself. So it's better if you go with treatment rather than getting a DEXA scan or extra scan as well. Okay. So here the answer would be B. So that is the best among the other options. So vitamin D, calcium, and bisphosphonates are supplements. So this is the that is the best answer for that particular question. So moving on to the next question, a 24-year-old man is brought to emergency department. He suffered from a crush injury to his forearm. Assessment demonstrated arm is tender, red, and swollen. Tender, red, and swollen. That is the most appropriate course of action. So what exactly is happening here? Crush injury. So first is the crush injury. So basically the arm is crushed, tender, red, and swollen. Clinical evidence of ulnar patient cannot move his fingers. So the problem here is the patient has a fracture. Because of the patient has a fracture in the forearm compartment. So what is going to happen when the patient is having a fracture? The hematoma here get accumulates inside the forearm because the fascia here is very tight. The fascia is very tight. It doesn't yield. It doesn't yield. So it keeps on stretching. It stretches to a certain extent. After that, the fascia also stops stretching and the fluid is accumulated here, and the compartment pressure rises. So what is happening when the compartment pressure rises? So this is a compartment. So this is the radius and ulna. So the anterior compartment, the posterior compartment is there. So anterior there are two compartments: the superficial compartment and deep compartment, and posterior compartment. So these are the compartments of the forearm. So when the pressure is increasing in this compartment, usually the deep compartment is where the pressure increases easily. So when the pressure is increasing and the fascia is not letting go, it becomes a closed space. So it becomes a closed space. So in this closed space, when the pressure keeps on increasing, the vessels are getting compressed. Okay, for example, consider this is the radial artery. There's a lot of arterioles veins are going. So the pressure is now considered 15 millimeters of mercury is the normal pressure. If the pressure has gone up to 25 millimeters of mercury, all vessels get compressed. So from the okay, and nerves and other structures, because there's a compression here, this vascular flow of blood is decreased. Because of this lack of nutrition, this structure can go into gangrene. So this is why this intervention has to be as early as possible. Here, sometimes what happens, there might be the pulses might be palpable even when there's a compartment syndrome, because loss of pulse is a last sign that we see, because it needs a lot of pressure to compress a large vessel. So we have should not wait till that moment. So we have to make sure we identify the compartment syndrome clinically itself. It can be pain on passive stretch, a tense compartment, red swollen compartment. So all these are classical features. When you're trying to move the finger, then this patient might have pain. Okay, pain on passive stretch is a classical sign. There can be tenderness, local tenderness, and tense compartments. All these are clinical signs of a compartment syndrome. So we can easily understand have a compartment syndrome. The treatment of choice here would be a fasciotomy. So this is the treatment of choice for compartment syndrome. It's a clinical diagnosis. Coming to the diagnosis of compartment syndrome, it's always clinical. When you get a clinical suspicion that this patient might have a compartment syndrome, you can easily go for a fasciotomy rather than getting a Doppler done and ultrasound done. This is wasting your time because it's a very emergency thing that we have to manage this case on. Okay, so that is the answer would be fasciotomy. A 24-year-old man sustains a distal radius fracture during a game of rugby. Imaging shows a comminuted fracture involvement of the articular surface. What is the most appropriate definitive management? So here they're talking about distal end radius fracture. There are multiple fractures in distal end of radius. If you're talking about distal end of radius, there's a junction called corticocancellous. The cortical bone is the cancellous bone. So when there's a junction of corticocancellous bone, the fracture is usually called a Colles fracture. So here, when the displacement is dorsal, it's called Colles. When the displacement is olar, fracture. So these are the two very commonest type of Barton's fracture. It can be olar Barton's fracture if it's on the olar side. It can be dorsal Barton's fracture if it's on the dorsal side. So when there is articular surface involvement, there is the destruction of the articular surface. The problem here is he's a 24-year-old man. So here this distal end of distal end of the radius articulates with the carpal bones. So these are the carpal bones. So this forms a radiocarpal joint. So the problem here is being a 24-year-old man and he's a rugby player, we have to make sure here the reduction has to be proper. The margin of error for the reduction in a distal and radius articular fracture is very less. It can be plus or minus 2 mm. The step usually that comes on distal articular surface has to be less than 2 mm. It can't be more. There can't be a huge depression like this in the articular surface. If there is a huge depression, then the patient will have a radiocarpal arthritis. So because once the radiocarpal arthritis sets in, then the patient will have a lot of pain. Then the management becomes more and more tougher. So what we have to do is we have to make sure the distal end of radius is correctly reduced. So we have to reduce it. We can put a plaster cast, but the reduction we can't achieve a reduction here in the articular surface. But when it's a Colles fracture, it's easy to achieve the reduction. So in these cases, what we have to do is we have to open the fracture, reduce the fragments in a proper way, then we have to fix it. We can usually plate it or put a KY, but we have to make sure that the distal end radius articular surface fragments are easily reduced in a proper fashion, and then only we have to fix it. So the answer here would be an open reduction and an interval answer compared to other options. Open reduction and interfixation would be a better answer. Okay. Then moving on to the next question. 30-year-old man is admitted overnight following a road traffic accident. He has an open tibial fracture of 20 centimeter wound and an extensive periosteal stripping. So 20 centimeter wound and extensive periosteal stripping. His neurovascular is intact. So here it's intact. IV antibiotics and wound dressing has been administered in the emergency department. What is the most appropriate course of action? So here we have to know Gustler-Anderson classification to understand an open fracture. So here they're talking about because it's an extensive injury, it's a 20 centimeter wound with extensive periosteal stripping. They're talking about grade 3B. I'm putting it in 3B because the neurovascularity is intact. If that has gone, it will go into 3C. So because the periosteal stripping is also there, I'll go into 3B. So whenever there is a periosteal stripping, there is a lot of loss of vascularity. When there's a loss of vascularity, the bone has a higher chances of going into avascular necrosis. There's higher chances of infection. So there's higher chances that the graft that you put over that won't take up. So this patient might need a flap. So that is why it is very important considering this patient has a very large wound, considering it as a severe type of a injury, the bone union chances are less, it can get infected, the soft tissue might not take up. So considering everything here what I'm saying is this patient already IV antibiotics done. Patient needs an ortho plus plastic coordination and a extensive surgery to manage the bone as well as the soft tissue. So because the first aid is already given, I think we can go for immediate. We can go at a later date. We need not do it like immediately. This patient need not get the surgery like an emergency surgery because it's a very coordinated procedure and it takes a longer time. So we can operate this patient in a combined in a scheduled operating list. But we can do a combined skeletal and soft tissue reconstruction. So it's not an actual emergency because the patient has been managed and given a first aid in emergency. So we can wait and do it in a elective operation theater. Okay, need not take it as an emergency. So our option here would be D. So D would be better option for us to understand this. Going on to the next question. 30-year-old man presents with severe pain on the left hip has been present on and off since many years. He was born at 39 weeks of gestation by emergency cesarean section. After a long obstructed breech delivery, he was slow to walk and a child is noted to have antalgic gait. He was a frequent attender at primary care center and pains dismissed as growing pains. X-ray shows a complete destruction of femur lead and narrowing of the sternum. What is the most likely underlying cause? So this is not exactly a fracture. The problem here is this patient has been limping since a very long time. This patient has been limping since a very long time because he was slow to walk as a child. Why was he slow to walk as a child? There's a condition known as a developmental dysplasia of hip or a congenital dysplasia of hip. The problem with these conditions is the acetabulum exactly fails to develop. This is the articulation between the acetabulum and the femoral head. When the acetabulum is not developed, this femoral head dislocates proximally. It articulates with the ilium. So because of this is called a dysplasia, which dysplasia is failure of development. So this development has not occurred. So because of that, it displaces. When a kid starts to walk, this is already displaced here. He'll have some amount of shortening. When the kids, there is no, because initially when the kid starts to walk, the limp is not that noticeable. As the kid starts growing, this will displace more and more proximally, and this patient will have a large limp. Okay, large limp. And because here it's staying out of the acetabulum for a very longer time, this whole of the head can get destroyed. Head can destroy, the acetabulum is destroyed. So here it's classical return. There's a complete destruction of femoral and narrow acetabulum. These are the classical features of a developmental dysplasia of hip. or if congenital dysplasia of it. The problem here is we have to, because the female head is already destroyed, we are unable to conserve it. If this patient has come earlier during like 1 year, 2 years of age, then we will try to conserve it. We can get it down into the acetabulum and we can try to restore the joint. The problem here is it's already that phase has passed and the acetabulum is narrow as well. So here we better go with a surgery. We can do a total hip replacement in this particular patient. Otherwise, we will not have any other option. We can't conserve this because it's already destroyed. Okay, then moving on to the next question. A 30-year-old man injures his ankle playing football. Examination is a tendon, so both medial and lateral malleus. X-ray demonstrates a bimalleolar fracture with a displaced distal fibula fracture at the level of syndesmosis and fracture of the medial malleus with a talar shift. So these are the important points here. The level of syndesmosis, fracture of the medial malleus, distal fibula. The ankle has been probably reduced and splintered in emergency. What is the most appropriate management here? So this patient has multiple fractures. Okay, what is the fracture? One is the distal fibula fracture, tibia fracture at the level of syndesmosis is important along the talar shift. So when you look at the ankle joint is articulating distally with the talus. So this is the medial malleus, this is the lateral malleus, this is the talus. So when it's articulating, this forms a whole ecosystem here. So even one of the thing is disrupted here. It can be lateral malleus, medial malleus, or the syndesmosis. This talus becomes unstable. When the talus becomes unstable, what happens is talus shifts from its place. So because of this shifting is called as talar shift. So what does talar shift says? This ankle is unstable. So when the ankle is unstable, we don't have any other option rather than surgical fixation. We can't fix it with the external fixation. It's not required in a 30-year-old fit patient. If it's a patient diabetic, old age with multiple comorbidities, we can still think of external fixation where we try to reduce the ankle because surgery in a diabetic or a peripheral vascular disease can lead to gangrene or infections. So here it's a younger patient, everything looks fine, so we can go with a surgical fixation. So the option would be surgical fixation here because there are a lot of the whole of the ankle is unstable. So our method of treatment here would to stabilize the ankle joint. Okay. So that gets the conclusion of this particular session. Thank you for watching. Thank you.